Hello, friends. Today we are going to talk about arterial blood gas analysis. And over the next 20-25 minutes, we'll basically discuss some basic steps of blood gas analysis, which are the 6 steps. Most of you are aware of those steps. We'll talk about oxygenation, a bit about the anion gap and osmolar gaps and urinary anion gap. We will do a few exercises to use these steps of blood gas analysis, and we'll end up with giving you a handout about a blood gas analysis. So you must have seen blood gases of various forms. This is one of the printouts of blood gas machine analysis, and you can see there are many variables here, lots of them, some of them which we don't even bother to look at. But yes, out of these, when you really look at analyzing the blood gas, you only need a few numbers. The numbers which are encircled are the ones which are very important for a complete blood gas analysis. So you don't only need the pH, PCO2, and the bicarb, but you also need electrolytes for a complete analysis of blood gas. The method that we are going to discuss today, the Henderson-Hasselbalch equation, is the backbone of this blood gas analysis, where the bicarbonate, the alkali, and carbon dioxide, the acid, is balanced through this equation. And I'm sure you are all aware of this equation. We don't really have to go into the details of this equation, but what we do need to realize is that there are a range of numbers of values for each of these variables which are normal. So pH of 7.35 to 7.45 is normal. But when we do blood gas analysis, when you are going to analyze a gas, we will pick up one number as the normal for ease of calculation. So we take pH of 7.4 to be normal. So anything which is more than 7.4 is abnormal, and less than 7.4 is abnormal. So 7.39 and 7.41 both are abnormal. Similarly, we take the PaCO2 or arterial carbon dioxide of 40 as normal, a bicarbonate level of 24 as normal, just for the ease of calculations, understanding that these ranges are all normal. So there are many blood gas analyzers, some older, very heavy duty machines, to much compact machines with very good many number of variables, and even a very compact handheld machine which is available. All of these give very good reliable numbers, and they can be very well relied upon. So let's talk about the basic 6 steps of blood gas analysis. We'll go through all of these steps in one by one in the subsequent slides. So first of all, we see whether there is acidosis or alkalosis. Then we find out whether the main reason is respiratory or metabolic. The third step is only if it is a respiratory problem, is it an acute problem or chronic problem? If it is a metabolic problem, we find out, is there an anion gap with it? Then we look for the respiratory compensation for a metabolic problem, and still look for any other associated metabolic disturbances apart from the ones which are covered in step 1 to 5. So it sounds complicated, but it's actually very easy, and we'll see how it is. So the first step is the basic step. You have to find out whether there is acidosis or alkalosis. So a pH less than 7.35, you know there is acidosis. Acidosis is the pathophysiological process. If we don't know the underlying story or the pathophysiology, then we can only say that the blood is acidemic. So any pH less than 7.35, there is acidemia. When you know why is the acidemia happening, then you can say there is an acidosis. Similarly, pH more than 7.45 is alkalemia. Again, we realized that we would take the number 7.4 as normal, and anything on each side would be considered abnormal. If the pH is within this normal range, then an acid-base disorder is very unlikely. Though the pH may be normal in the presence of some mixed acid-base disorders. The second important step is to find out if the process is the acidemia or the alkalemia is respiratory or metabolic, right? So first, if it is acidosis, acidosis can happen only because of 2 reasons. Either because the carbon dioxide is increased or the bicarbonate is low. So if the bicarbonate is the main reason, it is a metabolic problem. If the carbon dioxide is the main reason, it is a respiratory problem. So if CO2 is increased and there is acidosis, we know the problem is respiratory. On the other hand, if the pH is high, there is alkalosis, there can be again only two reasons. Either the bicarbonate is high or the carbon dioxide is low. No matter what the primary problem, the compensation will happen from the other side. So if it is a metabolic problem, there will be respiratory compensation. If it is a respiratory problem, there will be a metabolic compensation. And rather than trying to cram this up, you just have to work it out logically. So if my carbon dioxide levels are high, which is causing acidosis, the bicarbonate, the body, the kidneys will try to conserve the bicarbonate to match the acidosis. So the compensatory mechanism for increased carbon dioxide, which is a respiratory acidosis, would be to increase the bicarbonate. Let's take the other example. Let's say there is alkalosis and the bicarbonate is increased, which makes it a metabolic alkalosis. So if there is metabolic alkalosis, the pH is high. Now the body will try to hold on to the carbon dioxide to increase the carbon dioxide and to match the pH. So this compensation now is respiratory to a metabolic problem. What is important to realize is that nature will never overcompensate. Like in the example of alkalosis, as the CO2 rises, the pH will become normal. But CO2 will never rise to such high levels that the pH switches from being alkalitic to acidotic. It will never overcompensate. This is true when the child is breathing on his own. But when we are doing all the breathing for the child, we are ventilating the child, all these equations can change because this is not nature playing, it is us trying to play with the nature. Okay. Step 3, if it is a respiratory problem, if the acidosis or alkalosis is respiratory, is this an acute process or a chronic process? So what we realize is again that acute process would happen quickly and a chronic process will take a longer time, which will give a significantly more time for compensation to happen. So if there is an acute respiratory problem, the metabolic compensation for that would happen, but would happen to a lesser extent. While if it is a chronic problem, the compensation would be much more pronounced. And we are talking about metabolic compensation by the kidneys. So in acute respiratory acidosis, whenever the PCO2 rises, the bicarbonate will also rise. It will rise by 1 for every 10 millimeters mercury innovation of PCO2 above 40. But if it is a chronic problem, it will rise by 4. This is for acidosis. For alkalosis, which is a slightly more slower problem, the similar changes happen, but at a higher extent. So for acute alkalosis, there is a rule of 2 for 10. And for chronic alkalosis, there is a rule of 5 for 10. Again, these numbers seem to be too complicated to remember, and there's actually an easier way to remember it. This is what we call as a 1, 2, 3, 4, 5 rule. So you make this 2 into 2 box and you write 1, 2, 3 is for the bicarb here, 4 and 5. And now the first column is for acute, the second is for chronic. The first row is for increase of CO2 above 10, and the lower row is for decrease of CO2 above below by 10. So if there is an increase in carbon dioxide above 10 in an acute process, the bicarbonate would move by 1. If there is a chronic problem, a chronic drop in PCO2, the movement of bicarbonate would be 5 for every 10 millimeter mercury change in carbon dioxide. So this is an easier way to remember this. Okay. Let's now move on to step 4. So we do the step 3 only if it is a respiratory problem. If it is not a respiratory problem and it is a metabolic acidosis, we need to find out if there is an anion gap. So we need to determine the anion gap, which is the cations minus the anions. So you have all the cations here, many which are measured and some unmeasured. And you have all the anions here, some that are measured, some that are unmeasured. There's always an electrical neutrality. And there is a difference between the measured cations and unmeasured anions, which we simplify by this equation of sodium minus the bicarb plus chloride. So these are the anions, this is the cation, and this difference is the anion gap. So there is always some anion gap, some unmeasured anions, which are there in the blood, which make up for somewhere between 8 to 16 millimoles per liter, or as an average of around 12 millimoles per liter. So if the anion gap is more, if this increases, you know there is some other anion which is contributing to the acidosis, right? So there can be two scenarios. One where the anion gap has increased because there has to be electrical neutrality. There is neutrality in the body, but this anion gap has increased. This causes a high anion gap metabolic acidosis. On the other hand, there could be some scenarios where the anion gap might not increase, but this bicarbonate might contract. The amount of bicarbonate might reduce. So the chloride usually increases because there has to be electrical neutrality. The other anion increases. And this gives you a situation of normal anion gap metabolic acidosis, but the compensation is because of increase in chloride. So this is also what is now commonly called as an hyperchloremic acidosis. So you can have a high anion gap metabolic acidosis and a normal anion gap metabolic acidosis, or a hyperchloremic metabolic acidosis. So whenever you have a high anion gap, it should get your minds thinking as to why is the anion gap high. There has to be some reason for it. It could be the lactate, it could be uremia, it could be sugars, it could be ketones. There has to be some reason for this anion gap to be increased. And there are many reasons for increased anion gap or normal anion gap metabolic acidosis. And you have to go through this, or you have to exclude these in your mind to come to a diagnosis. So it is very important to find out if there is an anion gap metabolic acidosis. Whenever there is an acidosis, there is going to be compensation. So for metabolic disorder, there is going to be a respiratory compensation. And this Winter's formula is the formula we use to find out if there is a respiratory compensation and whether that is adequate or not, right? So the Winter's formula is to find out the expected arterial CO2, which is 1.5 times the bicarb plus 8 plus minus 2. So this is the formula for the respiratory compensation. If the arterial CO2 is more than what you expect the CO2 to be, then you know that the CO2 is actually higher than what it should be, and that means there is an associated respiratory acidosis. If the arterial CO2 is less than what you expect it to be by this formula, then there is an associated respiratory alkalosis. This is a very important step and we should understand it. We will try to find out the respiratory compensation to a metabolic disorder. So if the compensation is adequate, your expected CO2 should be the same as your arterial CO2. But if your expected CO2 and arterial CO2 do not match, then there is an associated respiratory acidosis or alkalosis on top of the metabolic problem. A very quick and not a very good way of looking at this is to look at the numbers after the decimal in the pH, first two decimals. So let's say if the pH is 7.23, then for that acidosis, the expected CO2 should be 23. That is a quicker way, but not a foolproof way of finding the respiratory compensation to a metabolic disorder. The sixth step is also very important and it needs a bit of understanding. We still have to look at other associated metabolic disturbances, right? So what we now want to do is we want to correct for the anion gap. We know there's an anion gap metabolic acidosis. We will correct for the anion gap And this corrected bicarbonate should be 24. Once the anion gap has been taken care of by this formula, which is the measured bicarbonate plus anion gap minus 12, 12 being the normal anion gap. So whatever is the anion gap, you subtract 12 from that and add it to the measured bicarbonate. This should be 24 or normal. If it is not 24, then there is some other metabolic problem which is happening simultaneously. So if the corrected bicarbonate is less than 24, we want the corrected bicarbonate to be 24. But if the corrected bicarbonate is less than 24, which means there is an associated non-anion gap acidosis happening. While if the bicarbonate is more than 24, then there is an associated non-gap alkalosis happening. So you can think it in this way that you can have a metabolic acidosis with respiratory compensation and still have a non-anion gap alkalosis or acidosis on top of it. So if we do these 6 steps sequentially in all children, we are unlikely to miss any major metabolic acid-base disturbance which is happening in the body. So again, the 6 steps, acidosis or alkalosis, is it respiratory or metabolic? If it is respiratory, is it acute or chronic? If it is not respiratory and metabolic, we calculate the anion gap. For an anion gap metabolic acidosis, we look for the respiratory compensation. Is that adequate or not? And at the last step, we find the delta gap or the corrected bicarbonate, trying to find out are there associated metabolic disturbances happening. Okay, so there's also a concept of osmolar gap, which is the difference between the measured osmolarity and the calculated osmolarity, which is around 10 in most of the normally around 10. And it can be increased in some intoxications in most of the conditions like methanol or ethylene glycol intoxication. More importantly, sometimes it is not easy to differentiate the reason of acidosis or the reason of loss of bicarbonate. So the kidneys tend to excrete the ammonia, the hydrogen ion as an ammonium salt. So it excretes the ammonia as ammonium chloride and excrete H plus ions out of the body. We use this for our advantage to calculate the urinary anion gap, right? So urinary anion gap is the difference between the cations and anions which are excreted in the urine, and normally it is 0. But if there is a lot of excretion happening from the kidneys, the bicarbonate loss happening from the kidneys or the gut, to differentiate that, urinary anion gap is very often useful. And a very easy way to remember it is this term negative. So rather than calling it negative, we call it negative. So if the gut is reason for the bicarbonate loss or acidosis, the urinary anion gap will usually be negative. You need to do urinary anion gap only in rare situations where the history is not very suggestive and you are at a loss as to where is the bicarbonate loss happening. So we spoke about recognition of metabolic acidosis. We looked at the low bicarbonate as the reason, as one of the reasons of metabolic acidosis. And we measured the magnitude of acidosis by seeing the change in bicarbonate. But this PCO2 and bicarbonate, they are not independent of each other. Blood buffering is not the same in the extracellular fluid. And this almost assumes that all buffering is happening by the bicarbonate. This is the Boston approach. This is what we've been using. Another approach is what is known as the Copenhagen approach, where the PCO2 independent indices like the standard bicarbonate or the base excess or deficit is used for the recognition of metabolic acidosis. There is nothing wrong in any of these approaches. Both are actually interrelated. But today we are discussing about the Boston approach, the way we have not spoken about base excess or deficit. So we are talking about the bicarbonate and using it, which is the Boston approach of arterial blood gas analysis. You must have realized we haven't talked about oxygenation at all. That is because SpO2 is a very good tool of checking the oxygenation status. And most of the times, SpO2 alone is good enough to tell you the oxygen status. PO2 is important in certain situations, especially when you want to find out the alveolar to arterial oxygen gradient, because that tells us the degree of parenchymal disease. So if the parenchyma or the alveolo-capillary barrier is wide or diseased, this gradient, the alveolar to arterial oxygen gradient, will be high. And this relationship between the oxygen. So we always talk about oxygen as something which is separate and carbon dioxide which is separate, but they are both interrelated because in the alveoli, the oxygen is competing with the carbon dioxide as well as the moisture, the water vapor for the space. So this alveolar oxygen is competing with water vapor, with carbon dioxide and other gases for space in the alveoli, and this determines the gradient between the alveolus and the capillary oxygen. This alveolar oxygen is represented by the alveolar gas equation, which is the inspired oxygen, partial pressure of inspired oxygen minus that of carbon dioxide, the alveolar carbon dioxide divided by the respiratory quotient. We have taken an arterial CO2 here because we assume that because CO2 is very easily permeable, the arterial and the alveolar CO2 are going to be more or less same. This inspired oxygen will depend on the barometric pressure minus the pressures of the exerted by the water vapor. So this is the alveolar gas equation, which gives us a relationship between alveolar oxygen and the carbon dioxide. So you can see as the carbon dioxide increases, the alveolar oxygen will reduce because carbon dioxide is going to compete with oxygen and take up more space in the alveoli. And as a quick pearl, your arterial oxygen will usually be 5 times of the FiO2 if your lungs are normal, if the lungs are not diseased. Okay, I think we have discussed some basics of blood gases. Now let's do some few quick exercises to understand these before we finish this talk. So let's think about this child, blood gas in a 1-year-old child who is tachypnic, respirator rate of 55 with mild respiratory distress and SpO2 of 95% in room air. So pH is 7.3, PCO2 is 49, PO2 is 47, bicarbonate is 22. What do you think about this? Child is saturating well in room air, is tachypnic, mild distress, but his arterial blood gas just doesn't make sense. So always think, do you really need an arterial blood gas? In this situation, in this child, you probably never need a blood gas because most of the emergency management decisions will not depend on your blood gas. If the child is sick, and the blood gas is normal, maybe your machine is not working properly. If the child is absolutely normal and your blood gas is not normal, maybe the problem is with the blood gas. Maybe it is not an arterial gas. Maybe it is by accident a venous blood gas. So always think whether you really needed the blood gas and then think of it whether you have taken the right sample. And SpO2 is a very good indicator of oxygenation status. So if you have an SpO2 of 95 and a PO2 in 40s, you know there is something wrong in the blood gas, right? So think whether you really need the blood gas. Same child, the blood gas is repleted. So pH is now 7.38, PCO2 is 40, PO2 is 80, and bicarbonate is 22, which now makes so much more sense. But then again, it was probably never needed. Few hours later, this child now has tachypnea, has worsening. His saturation now is 88%. You put him on some oxygen by mask, 4 liters of oxygen, and the saturation is now 95%. You are concerned of his respiratory status. But with 4 liters of oxygen, he's saturating well. Tachypnea is slightly worse. Now, do we need the blood gas? This is an important concept to understand. And let us do this. So this is an exercise. Let's do this. Let's say the minute ventilation drops by 50%. The relationship between minute ventilation and carbon dioxide is linear. So if the minute ventilation drops by 50%, PCO2 is going to rise by 50%. So it was normal at 40, it increases to 60. So minute ventilation in this child who is worsening has dropped by 50% and the carbon dioxide increases from 40 to 60. Now let us do the calculation of using the alveolar gas equation that we just saw, and look at the PaO2 when the child was breathing room air versus when the child is breathing only 30% of oxygen. So in the first scenario, the alveolar oxygen, this is the barometric pressure. We have just taken it 747 for ease of calculation. Minus 47, which is the barometer, which is the partial pressure of water vapor. We multiply it with the room air FiO2, and the PCO2 is 60 with the respiratory quotient of 0.8. When you do the calculations, the PaO2 comes to around 72. So a child breathing room air, when the minute ventilation drops by 50%, the PaO2 is around 72. This is the alveolar oxygen. And if the alveolar oxygen and arterial oxygen are close by, the arterial oxygen is going to be closer to this. Now we put this child on 30% oxygen. Everything in this equation is the same. We have just changed the oxygen from 21% to 30%. And you see when you do these calculations, the alveolar oxygen increases to 135. It is a significant increase, which basically tells you once you have started a child on oxygen supplementation, it is very difficult to estimate the carbon dioxide. So till the child is on room air and saturating well, you can be reasonably assured that the carbon dioxide is okay. But if the child is even on minimal oxygen supplementation, CO2 is very difficult to judge clinically, and you would need a blood gas to understand what the carbon dioxide levels are. So this child that we were discussing, who has now worsened, is on oxygen but maintaining normal saturation, does need a blood gas to find out the carbon dioxide status of the child. Okay. So quickly, let's look at 4 different scenarios. What is the primary disturbance in each of the following gases? First, pH of 7.25, CO2 of 75, bicarbonate of 36. What is it? Acidosis or alkalosis? Acidosis. So acidosis can happen only because of either an increase in CO2 or a drop in carbon dioxide. The reason here is increase in CO2. So this is a respiratory acidosis. pH 7.5, CO2 75, bicarbonate 36. pH is 7.5, alkalosis can happen only because of either a drop in carbon dioxide or an increase in bicarbonate. So here the reason is increase in bicarbonate or a metabolic alkalosis. Look at this. 7.2 pH, CO2 14, bicarbonate 16. Acidosis can happen only because of drop in bicarbonate or increase in CO2. Here the CO2 is low. So the primary reason here is the drop in bicarbonate, which makes it a metabolic acidosis. pH 7.5, alkalosis can happen only because of either drop in CO2 or increase in bicarb. Here bicarb is low, CO2 is low. So low CO2 is the reason of increase in pH. So this is a problem of primary respiratory alkalosis, right? So we've seen 4 scenarios, and it is very easy to understand or pinpoint what is the primary reason for the metabolic disturbance or respiratory disturbance. Okay, let's look at this gas. Next exercise. pH is 7.58. PCO2 is 19.8, PaO2 is 94, and bicarbonate is 19.7, right? For the full blood gas interpretation, these numbers are not enough. We discussed that this gas, for complete interpretation, we do need the electrolytes to calculate the anion gap and do the complete analysis. But this is a smaller exercise with a specific question. What is it? pH is 7.58, alkalotic. Is it respiratory or is it metabolic? You can see pH will go high only because of an increase in bicarb or drop in CO2. Here, the reason is drop in CO2. So what is our interpretation? This is an respiratory alkalosis. Now we need to come to the next step. If it is respiratory, which it is it an acute process or is it a chronic process? So if it is an acute process or a chronic process, we do our 2x2 checkbox and look at this. So here the CO2 has moved from 40 to 20, a change of 20 or 2 times 10 change. And the bicarbonate has moved from 24 normal to somewhere on 20, or has had a change of 4. So for each 10 millimeter change in carbon dioxide, we have had a 2 millimole change in bicarb. So the drop in bicarb is 2 for each 10 millimeter drop in carbon dioxide. So this makes it an acute respiratory alkalosis with a metabolic compensation, right? So we use this grid of 1, 2, 3, 4, 5 to find out whether it is an acute or a chronic problem. Okay, let's look at this gas. A 4-year-old child, and here we will do all the steps. A 4-year-old child with pneumonia and low blood pressure has been on dopamine. She has been having nausea and vomiting for the last 3 days, and you do a blood gas, which shows a pH of 7.26, bicarbonate of 10, PCO2 of 15, PO2 of 65, sodium of 130, potassium of 3.2. She's on 80% oxygen, saturating 90%. Few other numbers, this chloride is 90, albumin is 1.8. So we have lots of numbers. And now let us do the blood gas analysis for this particular child. And let's do everything step by step. Okay. So let's look at the gas. So I've put the gas here in the box so that we can keep looking at it. First step, is this acidosis or alkalosis? So we all agree pH is 7.26. This is acidosis. Is this metabolic or respiratory? So the CO2 is low. It cannot be respiratory. The bicarbonate is low. So this is a metabolic acidosis. Now, because it is a metabolic acidosis, we can skip the third step. Third step is only if you have a primary respiratory problem. And we go to the fourth step to find out the anion gap. So here, we will now calculate the anion gap. So what is the anion gap here? It is the sodium minus the bicarbonate plus chloride. So anion gap here is 30, which is a high anion gap metabolic acidosis. What is also important here to realize is that the albumin is low, and the low albumin tends to underestimate the metabolic acidosis. So the anion gap is actually even more higher. So let's stick to this 30 as a high anion gap metabolic acidosis. So what's the next step? Now we need to find out the respiratory compensation to this metabolic acidosis. Is this adequate or not? And for this, we use the Winter's formula. So for Winter's formula, the expected CO2 should be 1.5 times the bicarbonate plus 8 plus minus 2. And when we calculate this 10 is the bicarb. It is 21 to 25. So our expected carbon dioxide should fall in this range. And what is our carbon dioxide? 15. So carbon dioxide is even lower than our expected CO2, which means there is an associated respiratory alkalosis. So this child has high anion gap metabolic acidosis with associated respiratory alkalosis. And there's still one more step that we need to do, is to find the delta gap, or to see whether the corrected bicarbonate is 24 as it should be. So now we do the calculations for corrected bicarbonate, which is the measured bicarbonate plus the anion gap minus 12, and it comes to be around 28. So our corrected bicarbonate should be 24. If the corrected bicarbonate is more than 24, which means the base is more in the body, it is an associated metabolic alkalosis. So now we have a child who has high anion gap metabolic acidosis with associated respiratory alkalosis and a non-gap metabolic alkalosis on top of it. So this is a mixed disorder that the child has, and you would be unable to decipher all of these unless you go through all the steps sequentially, right? One last exercise before I leave you with some practice exercises for you to do on your own. This is a 6-year-old child, asthmatic, acute exacerbation, not responding to bronchodilators. You have the blood gas, pH is 7.24, CO2 is 49, O2 is 66, bicarbonate is 16. You can see that the CO2 is raised and the pH is low, and so is the bicarbonate low. So you can see here that there is a mixed problem happening. But in this exercise, we are not going to go for the blood gas analysis. We'll just focus ourselves on calculating the alveolar to arterial gradient of the oxygen, right? So to calculate the arterial oxygen gradient, alveolar arterial oxygen gradient, we will use this alveolar gas equation that we just did in another example. So the alveolar oxygen is the barometric pressure. We have taken it as 747. We are above the sea level, so we can take it less than 760. 47 is the partial pressure of water vapors. FiO2, the child is breathing 40% oxygen. The CO2, alveolar CO2, is the same as arterial CO2, or we can take it to be the same with the respiratory quotient of 0.8. By this calculation, our alveolar oxygen should be 218. But we see our oxygen here is 66. So the alveolar to arterial oxygen gradient is 218 minus 66, or 152, which is very high. The normal alveolar arterial gradient should be around 5 to 10. So an alveolar arterial gradient of oxygen, which is this high, basically tells you there is a parenchymal pathology happening simultaneously. And that is one utility of oxygen, or PaO2, in the arterial blood gases. For most of the other routine uses in the intensive care units, your SpO2 works as well or probably better than your PaO2 in the arterial blood gases. So for the blood gas estimation of metabolic disturbances, the acid-base disturbances, the pH, the PCO2, the bicarbonate, and the electrolytes are more than enough to give you an idea, or for you to be able to find out the reason of the disorder. So I'm going to leave you with certain exercises. You can pause this lecture and go through these practice exercises. Work out those, because you have to do a lot of these exercises over and over again to get a hang of it before you can just look at a gas and have a fair idea of what is going on. So as I said, these are all real gases on real patients. You can take your time, go through these exercises, and try to come to your own conclusion as to what is happening. Okay. So at the end, I will leave you with this link. This is just a 5-6 page handout about arterial blood gas analysis. I will leave this link active for the next 2-3 weeks so that you have time to download it. And if you have any questions about any aspect of this lecture or the blood gas analysis, you're more than welcome to get back to us, either online or when we meet in person during the workshop. Thank you so much.